Hello, this is Renew Education. Again, we're looking at the lower on this case that I called the left side gap. And I explained in the left side gap number part 1 why I do that, but I just looked at the CT or the Pano version and it looks like there's this giant gap to me. It's not huge because the ridge height is actually still pretty good here. So let me go through a little bit of what I like to call the treatment assessment kind of measurements or guidelines here that I recommend. And here we've got a light green bone density. We have a light green IA nerve. We have orange detached gingiva, orange facial bone, and orange ridge height. So the ridge height affects the gingival tissue attachment there. So in the mouth, I'm not showing pictures of it, but you can see that there is a ridge, but you do have detached gingiva there. And in particular, when you are looking at that buccal mucosa and food is trapping in there after you have a restoration in there, the gum tissue looks kind of red, and what you don't want is to have any sort of recurrent infection going on. I typically don't see that happen, even in cases where there's detached tissue going up and down around the abutments and things. Those cases seem to be okay. I don't like to see it, but I do think that there maybe I'm uncomfortable seeing it, but I think I just don't see the problems. I see problems elsewhere. I see problems on chipping of the crown. I see problems of recurrent infection into the bone, but I don't see too many problems with the detached gingiva areas in particular. So I don't know why. Maybe the air gets in there and we have less anaerobic bacteria that goes in there. Maybe that's why. Anyway, so we got a canine here, and we're looking at what are we going to do across here? So you're looking at 3 functional teeth here. We're looking at tooth numbers. Let's see. Hold on, we got to start again. That's a problem. So Vince, you're going to have to try to edit this through. So I'm going to go back to tooth numbers. I'm going to start over again. All right. So maybe I'll capture this again. So we're looking at this area here from the canine back. We're looking at 3 particular teeth here to restore. Tooth numbers 19, 20, and 21 to get the primary occlusion back. He has the premolars here, and he's going to get the molar here, and we're going to restore the upper. But in particular, we're looking at where would those be and where would number 19 be, because you could also do 19 to 21 as a 3-unit bridge. So if that would be, let's say, where the first implant is going back, so let's say it would be there. Your second one could be right here as the premolar is, and you kind of can see that there's little socket sites. So his teeth are really scrunched together. This is a really tight arch through here. So he's got a really constricted arch going through here, and that makes it a little bit more challenging when you really try to figure out where the placement should be. But you could see it also, I mean, I already pointed it out here, but you're going to be putting crowns on, so you're probably like premolar. You want to stay away from this root because that root was right on top of that root. And then your third tooth is going to be somewhere right about here. So you're going to be looking at possibly 1, 2, 3, and then your crowns are going to come out to about here. Okay, so your occlusion is going to be through here, and your implants, let's say, would be here. If you want to spread them out a little more, that's fine, but your occlusion is going to be about 14 millimeters high, and I know you're not going to have 14 millimeters going down. You're not going to be putting in more than a 10 millimeter implant, probably in this case, at best 11 and a half. So you would be wise already that I can already tell you probably to try to do 3 implants, then 2. 2 would probably work. Depends on how strong the patient is actually biting and functioning on them. So let's look at the first premolar site right there, and the bone looks good. So I get a high rating on the bone there, and the width looks good. So this should be a pretty slam dunky case. If you do, I would do a 3.5 or a 4.0. In this case, no problem. Probably a 4.0 is probably your best bet because you get usually the mounts stay the same, and you have a little bit more girth on it. You get a little more surface area, and we don't have a nerve to worry about. So this is a great first implant case if you're a left-handed person. It's on the left side. If you're right-handed, then you get to use the left side. That's great. That's still an easy, straightforward case. The next site would be number 20. That would be something right here. And this is where the anatomy starts changing a little bit. And it looks like somebody grafted this site maybe before, because I see a lot of more density of material here. So that could be leftover graft material. You don't really know. But it looks like it's been healed pretty well. You also get a 6 millimeter. It's just you start to get the angulation change between the 20 and 21 areas. So starts to lose that facial wall a little bit here. You start getting a little bit of that change, and you get a little bit of that shoulder here. So here's where the nerve comes in, so, or goes out, I should say. And you know, you're not going to be in that site, but your problem is when you're trying to aim with your drill here, you better be dead on this one. You don't want to be going over into this area here. So you need to be anterior of this. It doesn't look like there's some anterior loop here. So if we go here, it goes straight out, and that's kind of it. So this is a nutrient canal here, but there's no loop going on. So as long as you stay in this territory here and don't drill too much further. So what I do is recommend people to actually take that measurement and go, okay, well, if I'm there, no matter what I drill, I can't go past, let's say, 14 and a half or 14 millimeters. So you would be pretty safe taking a drill that is made for 11 and a half. Usually those drills go to about a 13 length. So you should be okay going to full length on a 13. But you have to know your drills in this scenario, just in case you are too distal or you're driving it distal, you can avoid getting into the foramen and the IA nerve coming out the foramen here. So I only use drills that have built-in stops, and I know the exact length of those drills, so I know I cannot hit that nerve. So let's look at over here. Now let's look at number 19 area. So it would be right about here. So if we were there, let me get rid of some of these measurements here. And if we are here, now we're in the number 19 area. Your nerve is down here. And now we've lost that, when it is extracted, that facial plate bone collapsed in, and you have that defect. And that's where you have the detached gingiva problems and things like that. So you could do something here, and here, let me just put an implant in just so we can take a look. Let me start with the 4.2 by 10, just so we get a sizing idea here. If you went straight in. Now there are some techniques that are interesting that you can build that wall back. So there are, it's a matrix that screws into the top of the abutment. I don't know if they still sell it, but it's a titanium mesh. This is a perfect case for this, where you want to build up this wall here. So what it is, it's an abutment or a screw attachment that has a titanium mesh. So you flap the tissue away here, you decorticate it maybe a little bit here, but then you put this titanium, you put the implant in, so the implant's fixed, and then you have the titanium mesh going across, and you fill it with particulate bone here. You just put that mesh and you stop the mesh here, and then you suture it back over. I can't remember, there's a couple companies that have this type of graft, titanium mesh. I know Hyosin had it. I'm assuming they still have it. But that would be ideal. So if you're interested in doing a new technique, trying a new product, trying to do different kind of graft, trying to build that ridge back over, this is a great case for that. It's a pretty straightforward axis. You don't have other teeth in the wall, so you can see this. It is on the left side, but you should be able to find that position pretty well. You should be able to extract that tissue back pretty well. You should be very successful with this kind of titanium mesh abutment kind of a fixation in that particular area. So that's a pretty exciting piece to do. So that's it for the lower in this case. Other teeth over here, he'll need to kind of have dealt with general dentistry type stuff. So that's not a big deal. But now the question is, if you're doing a 4.2 here, do you do a 4.2 here and a 4.2 here and then splint them all together? Man, that's a tough one too, because you could do a lot of hygiene with them separated. A lot of dentists do like to splint them, so I would leave it up to what the dentist likes to do. So that's a bit for this one. If you haven't checked out the upper version of this, please check out the upper version. Like us on Facebook and subscribe on YouTube, and check out from our live broadcast. And we're all good. Thanks.